Good afternoon, everybody. Welcome back. I hope those of you at home had a fantastic lunch. We certainly have had here. We've had some fantastic sessions this morning. We heard from Dr. Jaslyn Jolie about the research and some of the things that she's been working on. We had the phenomenal panel just before lunch. And we're now going to move on to the third part of this kind of trio of sessions, and I'd very much like to welcome to the stage Professor Susie Downs and Dr. Amanda Salisbury, who are going to give you a great workshop on having difficult conversations. Thank you to you.
Right. Well, what an absolute pleasure to be here, and thank you so much to the organising team for inviting us. It's absolutely wonderful, and it's been an amazing meeting so far. If I could have my first slide, please. There we go. So my name's Amanda Salisbury. I'm actually an oncologist. I'm an interloper here. But for a number of years, Professor Downs and I have been doing sessions looking at communication skills and the cross-fertilization that can happen between oncology and ophthalmology. Because when we started thinking about it, there were an awful lot of commonalities in the difficult conversations that we have to have. They're about really serious things. People remember what you say. Your choice of words is so important, as Jaslyn was saying earlier. You have to approach this in a way that will empower people to carry on and have a positive take on what is life-changing news. There's often questions about the inherited nature of conditions. Quite often I have to tell people that they can't drive anymore. The more we thought about it, there were more and more topics. And I had to learn some specific things. I had to learn, what vitreous loss meant and how that was a bad thing if you were operating and how that might be a breaking bad news conversation you had to have. And we've developed some sessions to explore those parallels, to illuminate things. It is so important. An anecdote, unfortunately, I'll now never get a chance to verify this, but I've been told that when our late Queen Elizabeth, was starting public duties, her father, George VI, said to her, Lilibet, because obviously that was her nickname and he was her dad, you will have the same conversations over and over again, but people will remember what you say word for word. And there's an element of that when we're having these important conversations that we always have to remember. I'm going to start by, my screen isn't up here, so I can't see what's going on until I peer around the corner. Is that standard? Am I able to see my slides on this screen? No, not at all, fine, okay. No, well, that's fine. I'm going to step out here because I was grateful for being invited. I was also grateful that this plinth here wasn't any bigger, because sometimes, being a little bit height challenged, I do appear sometimes to be an unusually chatty piece of furniture. So I'm always quite glad to step out into the room. So I've commented on how breaking bad news is important, and we've heard those quotes from Jaslyn's research about being hit by a brick and all sorts of things like that. And the protocol for a satisfactory breaking bad news conversation is also useful for any difficult consultation. And some people shy away from the word protocol. I don't, because I firmly believe, like many of us here, that communication skills can be encouraged and taught. Of course, you start from different places. People have different styles. But we can help avoid making the classic mistakes that have been made for centuries since Hippocrates first said, come on in, sit down, have a cup of Greek tea. We've got some serious things to discuss. So it's really about avoiding things that you can avoid. And also, the most important time when you need something to fall back on, a protocol if you like, is when things are high stakes, when it's stressful. Any of you here that have done basic life support, CPR training, will know that you could work out what to do from basic physiology if somebody collapses in front of you. But you don't want that. You want to think airway, breathing, circulation. You don't want to have to work it out from first principles. And similarly, if you're accosted by somebody who's distressed or angry or upset, you don't want to be thinking, well, I suppose we could move somewhere else. You want to be thinking, setting, where am I? How can we move to somewhere more appropriate? Am I equipped for this conversation? Who do I need with me? How am I going to follow on? And you want that to be at absolutely a spinal response level so that you can concentrate on the patient and having that conversation, or the relative, or whatever it is. And the other reason for having A structured way of thinking about these conversations is that you will feel better about them, both when they go as well as they can be, and we can't get around the fact that these conversations are going to be difficult and life-changing and all of those things, but at least we can do them as well as we can. And not only is important when things go well, it helps you work out why that went well and adopting that and using it going forward, but if things go badly, you can work out how much of it was a misstep that you took, how much of it was just the way it was going to be on that day. So for all of those reasons, I wanted to share how in oncology we're trained to do this, and this applies to junior and senior doctors in oncology, senior nurses, anybody who's going to be in regular contact with these sort of conversations. Although the protocols may vary a little bit, in fact, the one I'm going to talk to you about, the SPIKES protocol, is very widely used and very widely understood, and I think it's worth exploring in all sorts of difficult situations. So we're going to talk a little bit about what the protocol is, how to use it, and a variety of other things. And I hope as we go through, because we've got quite a bit of time, if you think of scenarios or situations that you wish had gone differently or that went particularly well, it would be lovely to share those things in the questions afterwards, and we can gather knowledge from each other about how to tackle these things. And wherever possible, I've tried to highlight things that are shared with ophthalmology. Forgive me if sometimes I use oncology examples, because of course that's what I know. We're then going to go on to some cases, and my colleague, Professor Downs, is going to help with that. I'm often asked, and I was saying this to our lovely guests earlier, you know, when I say I'm an oncologist, you get two responses. Either, can I show you this lump, which is not very helpful, or I don't know how you do what you do. And when we have this conversation, I have to point out that not only is she an international inherited eye disease expert, she literally sticks needles in people's eyes. And, you know, I don't know how she does that. So, right. So, first of all, what makes it bad news? And it's the difference between the patient's hopes and expectations and about their health and the medical reality. And the further apart that is, the more difficult that conversation is going to be. The closer it is, the more somebody has come to a likely understanding of what's happening, the more straightforward, still shocking and difficult, but the more straightforward it will be. And the art of these conversations is to align those two things as gently and as kindly as possible. And that doesn't mean necessarily having hours to do it. The whole point about this structured approach, which is very flexible, you can spend as much time as you like on each of the steps, is that it helps you make use of whatever time you have, whether that's 10 minutes or 2 hours, you've got a way of making the most of it. Now, you can't always decide. The classic one about what is good news or bad news is when somebody's getting the news that they're pregnant. That might be the best news in the world. It might be an absolute disaster. You know, I've had a minor knee injury recently. That's been an annoyance and an irritation, but, and I want you to use your imagination here, if I was a candidate for the British ski team, that might be a life-changing thing. And so you can't always predict what news is going to be really devastating. So the 6-point protocol is very simple. And as I say, you could work this out on the back of an envelope, but it just helps that other people have done it. You need to be prepared. You need to know where you're going to be, who you're going to have with you, who is going to follow up on that information, who you're working with. You need to have read the notes or got the information that you need so that you're not constantly referring to that, obviously, when you're trying to talk to patients. Most importantly, you need to find out what the patient knows, and there are ways of doing that, and we'll come on to that. Find out what they want to know. Now, that's the step that is often short or long or glided over or ignored because we sort of assume we know, or we've had an explicit bit of information that we know, but it's important to think about it as we go past it. We need to share the information. We need to acknowledge the reaction empathetically, summarize, and make a plan. So as you can see, it is something that you would work out yourself, but it does help to think about how each of these points contributes to things. So, preparation, all of the usual things. Again, this is from an oncology sort of medic's point of view, but I think there are comparisons with everything, both personal and professional. Are you ready? Do you know what you want to say? Who is going to help support you and the patient, both during the consultation and afterwards? Introduce yourself, check who is there, Let's not get the consultation off on a terrible foot by assuming that somebody's wife is their daughter, or all of those things that can sometimes happen. Let's just check. If you're new to this person and this group of people, then try to make a connection with somebody that they know. It's enormously helpful to say, I'm sorry to be a new face to you today, but I've spoken to Dr. Jenkins, who you saw last week, and he let me know what we hope to talk about today. The elephant in the room: acknowledge anything which you and the patient can see makes things more difficult. Now, I used to have to do talking to people on whilst giving them chemotherapy, on the chemotherapy suite at the Great Western Hospital, and at the time, that smallish ward was shared with the gastroenterology team. So I would be saying, so how is your chemotherapy going, administering the third syringe of things? And from next door, somebody who'd just had some sort of scope inserted somewhere unspeakable would let rip with the most enormous expulsion of air, and all you could do was look at the person and say, I'm so sorry. The magic soundproof curtains are not doing their job. You know, and because you could share the elephant in the room that we were both noticing, that was otherwise a barrier to having a conversation, we could get on with it. And this can be anything. It can be masks. It can be people trying to build a new centre next door so that you have intermittent banging and drilling. It can be absolutely anything. It can also be when somebody walks in the door and you can see that they're already furious. Now, you know it's nothing to do with you because you've only just met them, and it normally takes a little bit of time for somebody to get furious with you. But it helps to acknowledge that immediately and say, do sit down, my name's Amanda Sotter. I'm so sorry, you look extremely cross. Can I ask what that's about? And they'll say, well, it's the parking, obviously. And you say, yeah, sorry about that. I have very little control over the parking. But it means that they can stop showing you how cross they are about that, and you can agree that the parking is rubbish and move on with the consultation. If you don't acknowledge these things, A, you don't know whether it's the parking or some other terrible experience that they've had, and you won't get very far. Another specific situation is sometimes when you have to move from where you've met somebody to where you want to have a conversation. Now, it seems like a trivial thing, but I have seen conversations go badly wrong because the poor registrar was rooted to the spot, being confronted by an angry relative, and they didn't know how to get to the quiet room where everything could settle down and they could have a proper conversation. And of course, the way to do that is just to start walking at a normal volume, because people will follow you. If you say, just down here, there's a nice room, we can have a sit down, we may even get a cup of tea, and we can hash all this out. Do come through here, and you just don't stop. If you've ever watched episodes of ER, you will see this happen all the time. So, find out what the patient knows. Now, this is critical, and you have to do it in a way that is not irritating and upsetting, because you don't want to invite the reply, well, I really hoped you would have read my notes, which, if you ask the question in a clumsy way, is what you're going to get back. So it helps enormously to say, look, I've had a really useful referral letter from your own team, and I know quite a bit about the tests you've had, but it always helps me to start from where you are. What have you understood so far? I've had to dig myself out of difficult conversations when I was a registrar. I remember vividly in clinic, again in Swindon. That seems to come up a lot, I don't know why. And I realised 20 minutes into a consultation that despite the referral letter saying that the surgeon had talked about the fact that the rectal cancer had come back, that information had not gone in. He hadn't retained that. And that awful moment of realisation, it took much longer to undo all that than it would have taken for me to just start, as I usually did, with, you know, what do you understand is going on? And you get so much information about that. You get so much useful information about where to start. I used to do breast cancer, and I've done that start, you know, I've had a letter from your breast surgeon about things. Well, what have you understood so far? And literally in the same afternoon, I had answers that began, well, I was ever so glad when they said it was a tumour and not a cancer, okay? Starting from a very different place here, to, well, obviously as a professor of molecular oncology, I was a little concerned about my HER2 upregulating, and I hope we're going to be able to talk about PARP inhibitors today. Okay, slightly different place to start the conversation, and you've saved an enormous amount of time and embarrassment and made the patient feel comfortable because you're starting with them, not sort of in a muddle. One particular thing we have certainly in Oxford, I'm sure in lots of other university towns and other places, is that you can be fooled by people's fluency and intelligence. It doesn't always mean biological understanding. And I learnt this when I had to talk to the mother of a dear friend of mine. Their whole family have firsts in English, all of them. I mean, even the dog, pretty much. And I used to go there for Christmas, and the party games were things like somebody would pull a novel off the shelf, tell you the title and who wrote it, and you'd all have to write the introductory paragraph, and then they'd read them all out, including the real one, and you'd all have to vote for which was the real one. So, you know, phenomenally articulate. But as we talked about whether this lady should or shouldn't have adjuvant chemotherapy for their recently resected bowel cancer, it became very clear that the pros and cons of that, I was going to have to start from a very different level. So, it also gives you a clue about this thing about the gap between the medical reality and people's understanding, so the preparedness for the news that you have. Okay. So finding out what people want to know. Now, this is the point most overlooked because we make assumptions, sometimes very reasonably, sometimes unreasonably, and it's most important the further the patient is from a full understanding, because people might want to say, actually, I can see this is going to be a serious consultation. I don't want to have this on my own. Can I come back with my wife, husband, brother, son? And that's absolutely the right thing to do. So you've given a warning shot, in a sense. They know that it's going to be that sort of conversation. You also have to be neutral, because it's not really fair to say to somebody, now, are you the sort of person that likes to know absolutely everything about what's going on, or do you just sort of go with the flow and let people tell you what's going to happen? Who's going to opt for the second option? That's just not right. You have to make them even-handed, because people obviously, as we all know, get ready for information at different stages. And they need an opportunity to say, without it seeming judgmental, well, there's such a lot to take in. Can I just know the next steps? And next week I know I'll be ready to hear about the longer term. And part of the reason that we find it difficult is that we don't like to be seen as the person that shirked doing that job, you know, that stopped and said, well, I didn't think they were quite ready to hear the bad news. You don't want somebody to think, well, you know, you didn't do your job fully, you didn't crack on and give them everything. But people want information at different paces. And following this sort of structure means that you can document clearly where you've got to, and somebody else, preferably you, but somebody else can pick that up and carry on. Sharing the information. Obviously, all of the things that apply to sharing any complicated information, we use clear language, we explain terms. It sometimes says don't use jargon. Now, clearly, you can't use jargon unexplained, but I do think it's very important to use the proper names for things and to explain words that have an immediate meaning, partly because people want to go out and find information for themselves, and they can't if they have a very woolly, wishy-washy idea about what's going on. And also because it's empowering to know what these things mean, because everybody else will be using those terms. So, for example, if I've got a patient having chemotherapy that's going to affect their sensitivity to infection, I want them to be able to stride into Cornwall District Hospital on holiday and say, I'm a patient on chemotherapy, I'm at risk of neutropenic sepsis, be taken to the front of the queue and given antibiotics within an hour. Now, they won't do that if they go in and saying, well, I'm having some drugs that might have a bit of an impact on how I feel. They're going to be waiting for 6 hours and, you know, not work. Start from the patient's starting point. Now, this narrative approach is really important because as an oncologist, and I think as a lot of you as well, we're often in the position of making sense of the story so far. This important thing, referring back to Jasline's talk about how lots of tests happen and nobody's quite clear about why or what the result is, and then it all comes as a shock. We're in a position to knit that together into a narrative that makes sense, both for the person hearing it and one that they can take away and share with friends and family in a way that makes sense. So you can start with, you weren't feeling very well, felt a bit tired and run down, so you went to see your GP. They did some blood tests which were not quite right, but not in a very specific way, so you then had a bone marrow test or a bone scan or whatever it was. That showed up a couple of abnormalities, which is why you went to Mr. Jenkins, who did that biopsy, and that's what we've got the result from. And then you're in. And that makes sense of it for people. And I'm sure there are absolute parallels with the series of tests that people have for eye conditions. All of the things about presenting information that we're all taught on any course, small chunks, pausing, checking understanding at each stage, and again in oncology, but I think it has applications elsewhere, to help bridge that gap between where people are and where you are in possession of the information, the hierarchy of euphemism. So again, I might say, you know, the biopsy from that lump did show some abnormal cells. They weren't growing in a normal way. I'm sorry today, it was a growth, it was a tumour, it was in fact a kind of cancer. And even that very short progression is a way of gently bridging the gap. It's not a brick in the face, as we heard earlier. And there are parallels. If there is a confirmed diagnosis, it needs to be said for all the reasons that we've discussed. But it doesn't have to be. If you can see that somebody's slightly flinching about it, you don't have to keep repeating it while they adapt. And the next step is acknowledging the reaction, which of course can range from absolute rabbit in the headlights to an explosion of fury or tears. Anything is possible and is completely acceptable. You have to allow time. It's humane and effective, and actually it saves time in the long run if you want to think of it that way. And you need to assess the response a little bit. Is it actually part of the normal range? Is it going to help people, or is there an element that might need some work to help people adapt and adjust? All of this comes from a book called Breaking Bad News, a handbook for professionals, written by a chap called Robert Buckman, who was an he was a Cambridge oncologist who spent most of his working life in Canada. He also did some early work with the, Monty Python team, so he had a very definite sense of humour. And he was largely responsible for developing this spikes protocol. And in his book, and I've made some adaptations to this, but the process is the same. In his book, he explores the way that we sometimes respond to things. And we've adapted this. I'm indebted to Professor Downs for helping me adapt this. So, for example, say you have somebody with retinal detachment and they're told that the consultant has suggested repair under a general anaesthetic. And the response is, no, I can't have one of those. My tennis partner died during one of those 2 years ago. Now, in the middle of a busy clinic, sometimes you can think, oh, for heaven's sake, the mortality of that procedure is less than 0.5%. Not really a helpful response. It may be factually true, but it's not going to help anybody, really. A closed question is something that refers very specifically to the information that you've had. That may be okay. Do you think that's going to happen to you? An open question is perhaps more likely to be helpful because it may not just be specifically about that issue. So what worries you most about all this? It may be not just the risk of death, but it might be the risk of having a stroke under anaesthetic or whatever. And an empathic response, although it may not be the only thing you say, you can almost never go wrong with that because you're acknowledging the fact that what you've said has distressed them and that there's something to explore here. So that must have been very distressing for you. Have you been thinking that it might happen to you? Now, it might not, and so they've got an opportunity to say, no, well, it wasn't that because he had a terrible heart and we all knew that, and so we weren't that surprised, but I have been a bit worried about X or Y. So it's validating the fact that it's okay to worry about these things and to explore them. Again, this is familiar to all of you, I'm sure. You've been given the news that the condition is an inherited retinal degeneration, which is a progressive condition with no treatment. So, and the question that comes back is, how will it affect my life? So again, a factual response might have a useful place. A change in vision is usually slow over time, although, as we've heard, it needs a bit more qualification and expansion either then or later. A direct response which shuts down conversation is, let's face all that as we come to it. An open question, can you tell me what you're most worried about? That might be useful because it might be very particularly their aspirations to join the RAF or whatever. Or an empathic response, again, you must be very worried about the future. It doesn't do harm, and you may actually enable somebody to articulate what's most distressing them and help them at that point. You have to be very careful about language and not make any assumptions. So the question, how long will it take? You must check what you're talking about because you might think that the reference is, say, to the average time it takes to be registered sight impaired, and the patient is thinking about how long they can continue working or driving. This question, had resonance for me because I've had it where the question actually they're referring to is before I get better and go back to work, and I've interpreted as actually how long have I got to live, and that's a very awkward mismatch of conversations. How long have I got before I can't see? My, obviously, comparison there is how long have I got to live? You can give as straight an answer as you can, but I would generally avoid numbers. I learned this because, again, Swindon Clinic. I was talking to somebody who'd seen my consultant the visit before, and they were absolutely adamant that they'd been told that they had 2 years to live. And I knew I'd heard my consultant do lots of chats about that, and I knew he never said anything like that. And I looked through the notes, and very helpfully, he'd recorded what he'd said verbatim. He'd said, I've explained that the outlook is in months to years. And they heard 2 years, and 2 years became fixed. And although we may have information that has a number like that from studies of thousands of people, that's very rarely helpful for one person in front of you, because if the median is such, half are going to get less and half are going to get more. So it's only going to be true for a very small number of people. But it does, facts help you pitch your answer in the right ballpark, and that's generally what people want. They need some information, but also to know that nobody can say exactly what will happen to them. So some, a few, several, probably many weeks, months, years is the sort of guidance. And certainly things that help explain how we assess those things. There may be technical things about the condition that they have, but also where somebody is right now and what the rate of change has been are immediately understandable things. So, if somebody's vision has been changing very gradually, but over a period of years, then it's easier to understand that it might take several more years before there's another detectable change. Will it get any better? Again, you have to be truthful, but also remember that adaptation can bring functional improvement. And this comes back to the, I'm with Jasleen on this one, I'd have a small chip inserted that made people explode if they said, there's nothing we can do. Because that's almost never true. You have to say the truth, which is, I'm afraid there isn't anything specifically that we can do to improve this aspect of things. But what we can do is this or this. And people's ability to adapt is endless and unlimited, even if the physical condition that they're dealing with is fixed. And then at the end, you summarize and plan, and you need a review of the short narrative, which is what you want the patient to have in their mind to be able to tell other people, because that puts them back in the driving seat of their own situation, and to make sure that we've got that right. You try to include positive but always true things, and sometimes that's easy and sometimes that's hard, but there's almost always something that we can say about the resources that are available to help, or the adaptations that can be made. What and when will happen next? Contact person, you, the genetic counselor, the ECLO, consultant secretary, etc. And written or taped information is always helpful, because we know that people don't retain a great deal of what is said in difficult consultations. There's published evidence in oncology that people retain less than half of the information that they're given in a consultation where they hear that they have cancer. And I've heard read an American oncologist describe this as the tinnitus of terror, which is somebody with a bit of tinnitus, a little bit myself. I quite understand that once you've heard that news, that diagnosis, it's really difficult to focus on everything else. And this is partly why some people feel that they haven't had any information. It's so difficult to take it all in. And it's got to come consistently from a series of people in a series of helpful ways. So there are specific difficult situations, which I'll come back to in the summary in a minute, but responses like, you're tapped in the corridor by a relative and you mustn't tell her if it's bad news. If somebody, the gap between how somebody feels and the gravity of the news is something that happens in both situations, and that gives you a huge psychological divide. People that come to me I do head and neck and skin cancer, and people that come to me who've had months of difficulty swallowing, weight loss, earache, throat pain, lumps in the neck, they know something is wrong. They're not surprised. They may be distressed, but they're not surprised to hear that this is cancer that's causing it, because their physical state and the news is very close together. But if somebody comes, as happens for a proportion of my patients, people in their 40s or 50s, who have a lump in the neck, they don't feel unwell at all, they've just got this slightly persistent lump, and testing of that reveals that they have an occult cancer in the tonsil or the tongue base, and we're describing treatment that's going to occupy the best part of 6 to 9 months, and change various aspects of very important parts of their life, like eating and drinking. And there's a real disconnect there because it just doesn't feel real. And that you have to acknowledge is a perfectly normal thing, and to help people through it. And of course there's the shared things that have been highlighted, driving inherited conditions and what that means for families, dealing with uncertainty and sometimes misdiagnoses as well. And all of these we have to try a way of talking through in a helpful manner. So the 6-step protocol is a useful tool for all consultations, and breaking bad news in particular. Doing it well is good for the patient, for your well-being, general staff morale, time management, almost everything. Nobody gets it right all the time, and thinking about alternatives helps you to do it better next time. And the answer to the question is, how do you do being an oncologist? Well, one of the ways I manage it is to always think about how can I do it better next time. And this sort of format helps me think about what went wrong. Now I'm just going to very quickly go back to the list, because our amazing panel earlier very kindly said I could reference some of the thoughts I had listening to their testimony, which was extraordinary. So the setting, I think, applies to everybody, the preparation and the importance of having the information. The perception, Jen said, despite having growing up in a family where RP was talked about very freely, she hadn't really considered that that would be the diagnosis for her. So imagine if you barged in saying, well, obviously you know what's wrong. Clearly, it's barn door obvious, you've got the same as your dad and your granddad. I mean, that's a disaster. Finding out what somebody knows, I would have avoided that huge foot-in-mouth moment. That thing about what information do people want to know. Now imagine if Bobby had come, not with Lou, but with several of his uncles, who I imagine are as big and broad and bearded as he is. And they're all sitting there, glaring at me, and I want to know what Bobby wants to know. And the only way around that, and in fact this happened to me, not with big bearded Cardiff people, but with a nevertheless quite fierce daughter of a patient. She tried to talk to me beforehand and say, you mustn't tell Mum that she's got bladder cancer. My dad had Parkinson's disease and rectal cancer, and we never talked about the cancer. It was shameful, we just did not mention it. If you tell her that, she will collapse, probably die, and it will be the end of her, and she'll have no quality of life. And I was sitting in the consultation, the patient was sitting in front of me, her daughter was sitting behind the eye line of the patient and was going, don't tell her, was doing kind of, don't tell her, sort of just savagely cutting me off as we were moving through this. And in the end, this was an elephant in the room. So in the end, I had to say, I'm going to stop there, Mrs. Barnes, because I can see that your daughter's getting very upset. And I think she's upset because this conversation is upsetting you. And it always helps me to know, what do you want to know? What are your questions? And bless her, she said, well, I know something's up. I know it's something serious. Everybody's talking about it in corners. I've got to know what's happening. Can you please tell me what the heck is going on? And suddenly, I'm not the baddie ramming information unwanted down somebody's throat. I'm the person helping. So it helps refocus on the person in the room. And it's also a useful tool if you have cultural considerations, like with Yannan. Now, I might know something about the attitude to visual impairment in China. I might know a bit, but what I don't know is whether Yannan has those aptitudes or ideas, or whether her family does. Clearly, they had a very different, very enlightened view of things. I'm only going to find that out by asking. So cultural understanding and information is great, but you can't assume that it applies to the person in front of you, because we're all individuals. The knowledge sharing, that's really important. Faye and her son Joe, there was no family history. They didn't have that hinterland of general understanding of what that might mean. That section's going to need expansion and a lot of care and time to bring that family up to the same level of understanding. And it might also be helpful when you have, I mean, this is slightly an aside, but it rang a bell in my mind when they described trying to encourage Joe to talk about difficult things or the future. Sometimes in oncology, we have people who absolutely do not want to talk about their cancer at all. And if that doesn't stop useful things happening, then that's actually okay. That may be the way they want to manage it. But you have to make it as easy as possible for people to ask questions. So you might say, are there any times when you think this might not go very well? Or when you worry about certain things? Is there 5 minutes when you have a bit of a wobble or you have a think? And sometimes that time-limited opportunity to talk about things is bearable and people can start opening up a little bit. When we get to the acknowledging the reaction, well, that's our opportunity, as somebody from the audience said, to ask questions, to be kind, and as Yanan says, not to shout. So that's the time to display our general ability to communicate, and the summarize and plan, which has to be individualized. So you could, say to Jen what a wonderful asset that was to have that family example that was going to help her through. I'm sure Joe was as delightful, intelligent and personable at 8 as she describes him now, and those qualities are going to help see him through to whatever. Bobby's determination, Yanan's drive to improve conditions for everybody. There will always be things that you can, personal strengths and attributes that you can encourage as an adaptation to this. So I'm going to go back to where I was, and thank you very much for letting me highlight that in that way. So there has been a little bit of research on communication skills training in ophthalmology and optometry, and somebody had a stab at adapting this protocol for ophthalmology clinic. And it's all very similar, apart from the fact of paying greater attention to the barriers to eye contact and to being able to talk straightforwardly. Ways of asking questions about what people have been worrying about. It's really an expansion of those things, and some examples of the sort of questions that people might use about how much detail people like. Is there anything else that you'd like me to talk to? Anybody else you'd like me to talk to, etc. And then in the second half of the protocol, warning shots which are the same all over the world, starting chronologically, building that narrative to make sense of all those little bits of information, avoiding but explaining jargon, specifically explaining about the role or not of glasses, because you can bet that somebody's going to go home and get asked that question, and acknowledging that that's a conversation that has to go round several times in different scenarios. Acknowledging the reaction and a summary, including a positive plan with where the information is going to come from, the fact that they're not alone, and the fact that there are organisations like this one to provide wonderful help. So that's just highlighting the book from which a lot of this is derived. He also wrote a second book called Difficult Conversations in Medicine, which I'm not sure adds hugely to the first one, but does come with a DVD, which is always nice. But it's out of print, but it's always available on Amazon, and I would highly recommend it. And again, there's a couple of papers for those interested in this is beginning to be discussed in the way that it has been in oncology and many other branches of medicine, and looking at the specifics of things. So we now come to some cases. I will hand over to my colleague.
So I thought we would go through some cases to try and illustrate some of those points. And I have a case to start with whom I saw myself, and I'm going to show a couple of pictures. I'll describe them for individuals who can't see those. But this is a 16-year-old female who was trying to see the whiteboard at school and just couldn't see it properly, and had mentioned this at home. So they were taken to see the optometrist, and then they got referred in for testing. Now this is where I want to make the point that very often there's quite a long delay before diagnosis, because individuals have certain features at the back of their eyes which direct them towards ophthalmologists. Could be glaucoma, could be retina, could be this, could be that. Everyone thinks the eye's a small thing, everybody should know everything about it, but to be frank, just the retina, it just is a huge subject all on its own, and then you can divide it into acquired and inherited, which are huge subjects on their own. So I think we have to be careful to realise that the optometrist's job is not easy without all the tools that we have in ophthalmology. So firstly, this individual was seen. There was no family history, there was nothing wrong with their general health, and yet they had poor vision. And the vision I've written on here is 6/18, 6/12, which basically means it's not the usual vision. It's like if you were reading a chart, you'd only be able to get down to about the 4th, 5th line. So this child had a problem. And I'm showing some pictures here. The colour pictures, you can hardly see any abnormality on it at all if you're someone who looks at these images. So this would be what the optometrist would get, a colour picture of the back of the eye, either by looking in or taking a photograph, but they won't see a problem. So there's a child in front of them who can't see properly according to the child, and yet you can't see very much at the back of the eye. So you think, are they having trouble at school? Are they, difficulties with being bullied? Is there something funny going on? Has this child really got a problem? Now, with the introduction of more sophisticated imaging in most optometry practices now, this is starting to go away a bit, and we are getting the referrals more quickly, but some people go round the Rekin before they get to us. And then I immediately show a picture here, which is in black and white, which is called autofluorescence, which highlights large area of black really in the middle where the tissue is no longer working. And this individual has got a condition called Stargardt, and that is jolly difficult for an optometrist to pick up without sophisticated equipment. So this is a much more obvious version of the same disease, and it has quite a spectrum of appearance, and on top of that, it has something called phenocopies, which means different genes, different conditions look the same. So then we get into that difficulty as, what is it? And information should be given as you work your way along. And so when I see these pictures, I say to the individual, because I know that there is an inherited retinal problem, an inherited retinal degeneration, but we're going to need to do some more tests to work out exactly what type it is. And at that point, I don't have electrophysiology to tell me necessarily that that individual is going to have trouble with their edge vision or their central vision. I kind of know from my experience of years that this is going to be edge vision only. But I will ask certain questions to help me get to the bottom of it. So I will ask about, do you have any trouble with photosensitivity, i.e. trouble with bright light? Does the eyes feel uncomfortable? Do you have any trouble with adapting from light to dark? What I mean by that is when you go from the bright light into the cinema, is it difficult for you? Do you take longer than somebody else? Or do you truly have trouble with your night vision where you're actually in the dark and after 15, 20 minutes you still don't adapt, you still can't see? So I try to get all that information because that often steers me to what the prognosis is before I do any more sophisticated testing. But one is very loath to say to somebody, you've got this, this and this is what this is. In the sense of exact prognosis without your full information, because I don't think it's fair on the individual, but I think we have to share what we know as we go along, so that the individual then has the opportunity for the warning shot across the bows, if that's the expression we use, which is that they're aware that they have a condition that is progressive, they're aware that there are more tests that need to be done, and there are more things that need to be discussed en route. Genetic testing, driving, all these things. And I know for a fact that if you start off with driving, the consultation doesn't go to plan at all because the individual's so worried about their preservation of their independence, the loss of something that's so important to them, that almost everything else is not heard. So I think we have to be very careful. And I'm very lucky in Oxford that I have such excellent colleagues. In fact, one of them is in the audience today, Claire, one of our eye clinic liaison officers, who helps with picking up some of the wider questions. So I do try to give everybody information as I go, because I'm very cognizant of the words that Jasleen used earlier about not suddenly getting a horrible expression, but the brick in the face. You have to have information that you can work with, but we have to be accurate and we have to be careful about what we say, particularly with inheritance patterns, because people base their decisions about reproductive choices, they base their decisions on what they, the family tree, etc., before you leap in and say, this is definitely Stargardt. I'm like, looking at that picture, I'm 80-90% sure it's Stargardt, in the absence of a family history, with the absence of certain symptoms and signs. But I'm just saying, you've got to be careful before you leap in and give inaccurate information. You have to give as much information as you have, but it mustn't be inaccurate. So then we've got the situation, as I've said, Stargardt disease clinically, further tests required. So we might want to do electrophysiology. There's a lot of discussion at the moment about electrophysiology's role in this. I'm a great believer in it because I think it gives you a lot more confidence in saying what to expect over time. Then genetic testing, we've got to do the counselling and the follow-up around the genetic counselling. So that's a big thing in itself. Now, we've already spent half an hour or so talking about it, the actual condition, what might be the natural history, what you might expect, touching on the driving at this point, if that's appropriate. And then that individual who's already had a big shock to the system, if it's the first time that they've been told this, then has to spend time with our genetic counsellor to discuss aspects of risk to offspring. These sort of things are, again, quite difficult to take on board all in one go. We've already mentioned the driving, the genetic risk, and the natural history. Huge amount of stuff to take on board. So I think this pathway that was being discussed, I think is really valuable. We try to adopt that in our setup, but not always, it doesn't always work, and it can only work if you've got enough staff and enough time. And the NHS was highlighted as having some issues, and we're very lucky in our centre in that we do have space and time for it, but there are many centres that don't. So another thing that I find myself having slight difficulties in how to introduce the suggestion that someone might want some help with psychology. We have an excellent child psychologist in the eye hospital attached to inherited eye disease or any visual problem in young people. And it's quite awkward how to introduce that, to say to somebody, would it... So when I've finished everything, and I can see sometimes, and I offer it to everybody, whether or not they look upset or not, because I sort of feel you ought to have that opportunity if you wish to have it. But it's quite difficult broaching the subject, because if you say... so what I say is I kind of make it more generic, and I say, you know, many people who've had this kind of diagnosis, it's actually it's quite a shock to the system. It's quite a big thing to take on board. I've told you lots of things today, and sometimes it can be very helpful to talk to somebody who's not medical, who's not the family, but who you can talk things through with. And we're very lucky here that we have Dr. Ian McCubbins, who could talk to you a little bit more. He is a clinical psychologist, and if you wish to take advantage of that, we can organise that for you. You can, and if it's a young person who likes emailing or whatever. So I try to do it like that, without saying you look as though you could do with some help, you know, etc. But it's how you couch it, and it's everybody's different. And then I'm very keen that the community visual impairment team or anybody who's relevant gets involved quite quickly with children. So I very much rely on the ECLO and the low visual aid optometry team to help steer that. And I write the reports as necessary, but we try to do the signposting, and we have printed leaflets to help people with that side of it. So number 2, the second case, 27-year-old male, and he was referred because he was noticing some sparkling lights in his vision. Otherwise, he hadn't really noticed any visual disturbance. He'd always had poor hearing, and he wore hearing aids, so he could hear, but not very well. But with his hearing aids, it was okay-ish. And he was a travelling salesman driving, no family history. And again, he had these colour images, which I'm showing now, which showed absolutely no abnormality. And so you have to look in the periphery to see if there's any pigment change if you're thinking about possible retinitis pigmentosa, particularly as this gentleman didn't have any issues with night vision. Or did he? That's the thing. sometimes individuals won't tell you because they think it's within normal range. Some people have difficulties with it, some people have pronounced difficulties with it, others have a bit, others have had it since they were very young, so they think that's how everybody else is managing. So this image again is another black and white photograph, autofluorescence imaging showing a typical increased ring of autofluorescence, which immediately told me this is what we're dealing with. There are some other things, but this is, for this case, this is essentially what clinched it. And then if you looked in the far periphery, there were some little areas of atrophic change, missing tissue, and his visual fields were incredibly constricted to they were less than 10 degrees, and he was driving. So we've got a situation where he either doesn't really realise or doesn't really want to know, well, not want to know, but doesn't really want to acknowledge the situation. And you know, as Amanda says, with that, you know, the distance between what he's thinking and what you know is very, very difficult to bridge. So we've now got dual sensory impairment as well, because he's already got hearing issues, and now he's getting, well, has visual impairment. So what's the prognosis for him with this? He's driving, his work depends on the driving, family implications, psychological implications when we go through things in more detail, and uncertainty. So how do we address all of these, and is it going to be possible within the environment that we're trying to do it in? So I don't know if that would be a case that we might discuss a little bit more, how to break that news to him, because he's quite either in denial or quite unsuspecting of what's coming his way. So,
I think, I mean, clearly, it's a situation where a warning shot is really, well, being waved at here. I think we're giving our 5-minute warning, is that right? He broke the bad news beautifully there with a hand gesture, so yeah. Let's remember that one. Yes, so clearly establishing where he is and then expanding that a little bit. Have there ever been times when you've worried that your sight isn't as good as it might be? Or have you been worried about the fact that you've been having all these tests and everybody seems to be concerned? I'm sure it's made you, worried that there might be something more serious going on. And that gives him an opportunity either to say, yes, I have, and actually it's a relief to talk about it, or, do you know what, I've got to come back on another day with my support system because I've got to come back with somebody. You're just pacing it gently, truthfully, kindly, trying to approximate those things. And I think the switching focus from the individual to groups of people who might share that experience is really useful. I do this with prognosis because you can't say what the individual's experience will be, as well as saying some people find talking to, who've had this shocking news, some people find talking to a psychologist helpful. That's much easier to take on board than, as Susie said, you look like you need to talk to a psychologist. So similarly, you can use that to make it feel less pointed, the conversation less pointed, and then draw it back to the person.
And it's just very important to get the diagnosis across, explain it, the natural history of it, what's expected. So I tend to say inherited retinal degeneration is a condition that has 1,000 different types. Lots of different genes cause it. There are a variety of different types. Some affect the centre, some affect the edge, some affect both the centre and the edge, and some of them progress at different speeds. And basically, you have this particular type, and as again, there are many different types within that, you have quite significantly constricted visual fields. What that means is that your edge vision has been damaged by this condition, so that if I wave my hand here, and I try to illustrate and explain it.
Explaining jargon. So you've got the specific term, so if you need to Google that and what implication that has for your driving, you can do that. But you've also had an explanation in real human words about what that means.
And then we go through it all in a bit more detail. I'm conscious that we're running out of time, but
perhaps we should just, if there are questions or comments.
Yes, that we should stop there.
We should allow a little time for that.
So any? Yes.
I think the interesting thing there is that with the hearing impairment.
Can we just wait for the microphone so people at home can hear as well, please?
the interesting thing there is that with the hearing impairment as well, you've got to make sure that the information that you're giving is understood as well, because working with people with hearing impairment, you know, and visual impairment, the possibilities can go anywhere and everywhere.
Absolutely.
So that's the other thing in the room.
So you need to be aware that you might need an interpreter, you
Yeah.
may need someone who signs on the hand,
Exactly.
you may need all sorts of different... This gentleman could hear, but for that, the cases you're saying, absolutely, and you have to have access to those, and sometimes you have to make another appointment to make sure you have the right people there.
And you have to have tactics to bring that conversation to a satisfactory conclusion and say, look,
That's
you
what
know,
I was gonna
here's where
ask
we
you.
are.
So that's exactly my
yeah.
question. That how would you do that? How do you bring that conversation around?
I think you address the difficulty that you can both, that you're both aware of. You say, we've been able to share a certain amount of information, but I can see that we need to have a much more detailed conversation.
Right.
How can we make that easier for you? Would it help to have, you know, a BSL translator, or would you like a family member, or, you know, let's make this a conversation that is as easy for you as we can make it.
Brilliant. Thank you. Thank you so much.
And make it clear that that's why you're finishing the consultation, not because you know, just time's up, but the circumstances are not right, and that you're going to do something about that.
And you have to allow an extra amount of time for that, because it does take a lot longer.
Thank you.
Oh, one at the back.
Yeah, hi, I'm Eamon Dunn from Thomas Pocklington Trust. Figures from RNIB suggest that only about 17% of people going through sight loss journey are offered support with emotional well-being. What your situation in your hospital sounds really good, but that the majority of people don't seem to be getting offered that support. What can we do about that?
Okay, so the way we got it, we were jolly lucky in that there was a project, I'm going to be awful and forget who it was, Retinal Action, or Action in Retina, RAG, Retinal Action Group, came to me and said, one of the individuals within the group said that his offspring had nobody to support, so would I be interested? So they raised some money, I approached a psychologist, we worked together, and it's now incorporated and the NHS pays for it. But originally it was driven by a champion led by Retinal Action Group, and I think it should be something that's available for all sight loss, whatever type, inherited or whatever. And it's not just, this chap's very kind, and he sees the older people who have had issues all their lives, who've never had that help. You know, he saw a 45-year-old for me the other day because he's able to do that and feels confident to do it and does it appropriately.
I think that, to use a parallel from oncology, the way that new services like that are sometimes developed is Macmillan will take on the funding for the first 3 years. They'll set up a post, it's badged as a Macmillan post. They will pay for the first 3 years if they have agreement from the trust that's going to make use of that post, that they will carry on the funding after that. So it's sort of pump priming funding, and then it's forever badged as the Macmillan clinical psychologist or whatever, but the trust take on the funding, and that's a formal arrangement. And that's been quite a useful model. Lots of clinical nurse specialists in cancer are funded that way, if you have a charity with big enough pockets, obviously.
And that's similar to how this was set up. Yeah. The trust, it did it for 3 years, and then the trust took it over. Kate.
Hi, I've got a question online. Obviously with driving, you mentioned driving, and it's been mentioned today a couple of times as a big point of impact. You're going to have to tell somebody straight away there and then that they can't drive any longer. Have you got any tips on how to do that sensitively?
Yes. Yeah. You do it in your speciality, I do it in mine. But I do leave it till the end so that the information about the condition itself has had a chance to be absorbed. And I always say this is very difficult, but do you drive? And then if they say yes, then I explain, well, I can just say how I do it. I just say, well, I'm going to have to tell you that with the visual fields that we've taken today, or whenever we did them, if I can show you, and now if someone's vision's up to being shown, which it usually is, because the centre in RP usually remains, as you know, satisfactory to be able to drive as long as they have been driving, I show and I say, and I don't know if this is a wrong thing to do, and I've always meant to ask somebody else, but I've been doing it for a long time. I say, well, with those visual fields, for example, if you were in your car and you're on a zebra crossing, And if an individual came from that side, you would turn to see them. But if a child comes here, you won't see them because your visual fields, you can't compensate because both of your visual fields, because many people have what's painting in where they think they can see and they can't, and you can only demonstrate it by such an example. So I actually show the visual fields and I say, this is where they should be, this is where yours are, and this is... And I also say at the end of it, when I've finished it all, I do say that the centre in many people stays very strong for a long time so that it persists. So I'm not saying, you know, something's going to happen immediately, change is slow over time. So I go back to the original and go through that a bit again.
The other things, I mean, like Susie, I think it's helpful to appeal to somebody's best self, because nobody wants to be involved in an accident and feel in any way that it's their fault, and the fact that you can't control what other idiots on the road do. So they might drive into you, it then comes out that your vision isn't quite good enough, and then you find you're not insured and in a world of pain. So you highlight the sort of path of most regret that might happen. And then as a positive thing, I ask people to consider the money that they spend on a car, fuel, servicing, whatever, if they're the only driver in the house, and say, what you need to do is consider that your transport fund. And that pot of money is then to pay a driver, give them petrol money, hire taxis, compensate friends. You'll still have transport money. It's just that you can't, unfortunately, drive yourself. But it is very hard. Yeah.
But you have to do that quite sensitively, because nobody likes to be told that either. No. So it's a tricky one.
It's a very
and you
individualised.
Have to play it individualised.
And you know, I've had people walk in and they're wearing their bomber jacket with, you know, Antique Cars Appreciation Society, and you think this is really going to be a hugely devastating thing. This has to be approached with particular care. So, yeah. Somebody there?
Yes.
We're going to have to...
Yeah,
Okay,
sure.
That gentleman.
We'll take that.
Okay. Thank you very much indeed for inviting us to talk.
I wonder if there's a protocol on apologising to a guide dog for stepping on it. Yes. Right. Fantastic. Thank you ever so much to you both. A wonderful session. And I'm sure you can all agree it's some of those skills that you can take into all of your areas of practice, not just necessarily a point of diagnosis. It's every contact you have with any of your service users. Right. Last break of the day. And then you have some really exciting sessions. You've had all the professionals, you're going to have Kate, and then you're going to have me. So, you know, we kind of, you know, we're in for it. So, 15 minutes, and we'll have you back in the room. Thank you very much.